Hello and welcome to the topic of acute kidney injury and chronic kidney disease. By the end of this session, you should be able to define the criteria to diagnose acute kidney injury and chronic kidney disease based on the KDIGO guidelines, classify the conditions based on the severity and grading as stipulated by the guidelines, explain the causes of acute kidney injury and chronic kidney disease, describe the clinical presentation of a patient with acute kidney injury and chronic kidney disease. You should be also able to discuss the investigations performed to diagnose and stage the extent of the condition, and finally, discuss an approach to kidney diseases. Let's get started. First, we would look at acute kidney injury. Acute kidney injury refers to the acute deterioration of renal function, clinically manifesting as a reversible acute increase in nitrogen waste products, which are measured by blood urea nitrogen and serum creatinine levels over the course of hours to weeks. The Kidney Disease Improving Global Outcomes, or KDIGO, released their clinical practice guidelines for acute kidney injury, which builds off the RIFLE criteria and the Acute criteria. KDIGO defines AKI or acute kidney injury as any of the following: an increase in serum creatinine of 26.5 micromoles per liter or more within 48 hours, increase in serum creatinine of 1.5 times the baseline within the prior 7 days, and urine output of less than 0.5 mils per kilogram per hour for 6 hours. It is always best to have a baseline creatinine results to compare to the current results to diagnose acute kidney injury. However, having said that, in the absence of a baseline result, you would always assume that the patient has acute kidney injury and there is a possibility of reversibility. AKI is staged for severity according to the following criteria. Stage 1, where it reflects a serum creatinine of being 1.5 to close to 2 times the baseline, with of course decline in urine output for 6 to 12 hours. Stage 2, which is 2 to 2.9 times baseline, with decrease in urine output for more than 12 hours. And stage 3, which is about 3 times the baseline, and here you'd expect to see the urine output less than 0.3 mils per kilogram per hour for more than 24 hours, or the patient becomes absolutely anuric. The stages here are important because these two reflect the morbidity or the mortality risk of the patient. Next, let's look at the causes of acute kidney injury. They can be largely grouped into pre-renal, renal, and post-renal causes. Pre-renal causes include disorders of renal perfusion and structure abnormalities of the renal vasculature. Examples of conditions causing renal perfusion problems are reduced circulating volume such as seen in blood loss, excess gastrointestinal losses, and burns. Low cardiac output states such as in toxic or ischemic myocardial dysfunction. Septic shock, which incites peripheral vasodilation and perfusion compromise to the kidneys. And finally, drug-induced renal perfusion shutdown. This is seen in the use of ACE inhibitors, which inhibits efferent renal arteriole vasoconstriction, which in turn reduces the glomerular filtration rate. The use of NSAIDs, on the other hand, causes vasoconstriction of the afferent renal arteriole by inhibition of the prostaglandins and bradykinins. Another type of drug which can also lead to renal perfusion or shutdown include diuretics, and this is known to reduce the circulating plasma volume. Next are the renal causes. These include acute glomerular nephritis, interstitial nephritis, and tubular necrosis. How about post-renal causes of acute kidney injury? This is mainly due to the obstruction of the urinary outflow tract. This point of obstruction can be broadly categorized into two: extrarenal obstruction and intraluminal obstruction. Extrarenal obstruction causes include any extrarenal structures or organs which, either due to fibrosis or hyperplasia, causing direct compression onto the urinary outlet tract that drains the urine out. Examples are prostate hypertrophy, retroperitoneal fibrosis, and carcinoma of the bladder, prostate, or cervix. Whereas intraluminal obstruction happens due to the narrowing of the tract lumen, commonly caused by urinary calculus or invasive carcinoma or even urinary tract strictures. There are many investigations apart from just a renal function test that can be done in the workup of acute kidney injury. And this predominantly looks at identifying the potential cause of the renal injury. The most common test that's done would be urine analysis. Well, this helps you determine whether could there be a glomerular pathology, an infective cause, or a potential calculi that is causing obstruction and leading to an acute kidney injury state. Ideally, every renal function test needs to be appraised to a point of an estimated glomerular filtration rate. This estimates the function of the kidney. Imaging studies such as ultrasound, kidney ureter and bladder, or a CT urography can be very helpful in delineating a potential cause of obstruction in the renal tract. Apart from that, they can also be useful in measuring or identifying the size of the kidneys, as well as looking at if there's any presence of focal kidney lesions. An autoantibody profile is indicated in those patients with high suspicion of autoimmune disorders leading or having kidney diseases concomitantly, and examples include Wegener's granulomatosis, you can have Church-Strauss syndrome, or even SLE being the commonest. A percutaneous renal biopsy is usually preserved for patients where unexplained hematuria or proteinuria, difficult diagnosis, as well as monitoring the response to therapy in conditions which we have already diagnosed glomerulonephritis. This is an example of a urine analysis, and the container at the bottom of the slide shows you the different colors where you can compare and determine the state or presence of any one of these components. Presence of protein indicates glomerular disease. However, sometimes protein can also reflect an infection or an injury to the tract due to calculus. Presence of blood indicate possible glomerulonephritis, nephritis, infections, calculus or malignancy. Nitrites and leukocytes namely indicate the presence of a bacterial infection, nitrites being specific for gram-negative bacteria. Ketones are associated with dehydration, starvation, and low carbohydrate diet. The specific gravity of the urine provides information on kidney's ability to concentrate urine in relation to plasma. So these may be useful in certain osmolality disorders. And finally, glucose. Presence of glucose indicates presence of diabetes mellitus. Now let's take a look at the principles of management of acute kidney injury. First of all, identify the classification of acute kidney injury. Is it pre-renal, renal, or post-renal cause of acute kidney injury? Next, run the appropriate investigations to establish the cause as mentioned earlier. Provide medical therapy for symptoms relief such as diuretics, blood transfusion, or renal replacement therapy if indicated. Lastly, measures to delay progression of the complication should include good blood pressure control and avoidance of nephrotoxic medications in the treatment of other underlying medical illnesses. Now, let's take a look at chronic kidney disease. As the term suggests, Chronic kidney disease is defined by the abnormality of not only the kidney's function but also the structure that has been present for 3 months or more. So that implies the chronicity of the kidney disease. Or if there's evidence of kidney damage, such as presence of hematuria or proteinuria, which are characteristics of urinary abnormality, or presence of scars, or polycystic changes on a renal scan. Also, if the estimated glomerular filtration rate is less than 60 for 3 months or more with or without evidence of kidney damage, this is regarded as a possible chronic kidney disease. Chronic kidney disease refers to all 5 stages of kidney damage, from very mild damage in stage 1 to complete kidney failure in stage 5. The stages of kidney disease are based on how well the kidneys can filter the waste and extra fluid out of the blood. So stage 1 CKD refers to mild kidney damage with an eGFR of 90 or greater. Here, the patients may not have any symptoms. Signs of kidney damage could just be proteinuria, or there could be some evidence of physical damage which may go unnoticed. Stage 2 CKD means one has mild kidney damage with an eGFR between 60 to 89. Most of the time, an eGFR between 60 to 89 refers to kidneys being healthy and working well. But if one has stage 2 kidney disease, this means that the other signs of kidney damage may be present even though the eGFR is normal. Next, stage 3 kidney disease means you have an eGFR between 30 to 59. An eGFR between 30 to 59 means there is some damage to the kidneys and they are not functioning as well as they should. This is the point where the nephrologist referral is indicated. Stage 4 CKD refers to an eGFR between 15 to 29. An eGFR between 50 to 29 refers to kidneys being moderately or severely damaged and are not working as they should. Stage 4 kidney disease should be taken very seriously as it is the last stage before kidney failure. So measures that are advocated from stage 3 and above is namely looking at delaying the progression of the kidney disease and preserving whatever that's left within the kidney's function. Listed are the commonest causes of chronic kidney disease, mainly being diabetic nephropathy, which accounts for almost 20% of total cases, followed by chronic glomerular nephritis, hypertension, chronic pyelonephritis, polycystic kidney disease, obstructive uropathy, post-acute kidney injury, chronic tubular interstitial nephritis, and rarely amyloidosis. Early detection is done by targeted testing for chronic kidney disease among high-risk populations with diabetes and/or hypertension. So a renal function test and urine analysis are useful to stage the kidney disease. This is done based on the eGFR calculation. You may have existing calculators on your devices that would assist you with this. Imaging studies are also important to perform to ensure that we are not dealing with an obstructive cause of uropathy or nephropathy which is potentially reversible. Next, let's briefly look at the principles of management. So here, diet control and management is important. We want to advocate adequate fluid intake with appropriate monitoring. This is to ensure that this does not overload the circulatory system and the cardiovascular system of the patient as the renal excretion is slowly declining. Also, protein restriction in order not to burden the kidneys in excretion. Next would be electrolytes. So here, one of the functions of the kidneys is to maintain acid-base and electrolyte balance. So it is important to ensure that sodium is restricted in order not to cause refractory hypertension, as well as potassium adjustment, because the function of the kidney is slowly declining, hence the excretion of potassium also will decline, and this will then in turn retain potassium in the circulation. You may consider micronutrient supplements such as vitamin D, because the function of the kidney is also to activate vitamin D. Next, avoidance of nephrotoxic agents. Be mindful about the medications that we are prescribing. Ensure that there are no drugs that can potentially worsen the kidney's function. And if there are any drugs that require renal adjustment dose, be mindful about the correction of the dose. Lastly, pharmacological agents. Well, we can use some therapy to ensure that blood pressure as well as glycemic control is well strictly maintained to delay the progression of the disease. Now, in summary, ask yourself, if you see an abnormal renal profile or renal function test, is this AKI or CKD or ESRF? If it's AKI, remember to consider pre-renal, renal, or post-renal causes. If it's chronic kidney disease or CKD, think about a possibility of acute on chronic kidney disease, which is potentially reversible closer back to their baseline, or could this just be progression of the disease, hence the patient needs to be primed for long-term renal replacement therapy. We have come to the end of this lesson. We hope that it was insightful, and thank you for your time.